PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner, Dr. Raafae Hussain.
Hi, hello.
And we have survived the frozen tundra that was North Texas last week.
Yeah, it was in freezing temperatures. It was like 10, 15 degrees, and today it's in the 80s.
This is just typical Texas weather. Gotta love it. So we were completely shut down last week, but we've got enough canned content that we were able to publish last week. A interview I did with Tony Rodriguez, who is the program director for a new wound center that we're putting up here in Argyle, which was great. And I want to give a shout out to Tony again for doing that with us. That was awesome. So we haven't missed a week, even though we were just completely out of commission last week, which has been great. And our video editor, according to Michael Yoder, our guy who is handling a lot of the logistics and technical details around this podcast, the video guy is here in Texas, which I didn't realize. And so he was, out of luck.
Yeah, if you have no electricity, everything's frozen. What are you supposed to do?
You're not going to be editing video. So I think at this stage, we're fortunate to be back in the saddle, and the weather's beautiful here in North Texas, and we're seeing patients again, which is great. But today we wanted to change the focus over to Hallux Rigidus, which is an incredibly common problem that we see, a specific arthritic joint, essentially. So what do you got for us, Dr. Hussain?
So Hallux Rigidus, what is it? Typically a patient will come in complaining of big toe joint pain. We'll do our little physical exam, but commonly it'll be after activities. They are runners or they do a lot of walking for work and they start having pain in their big toe joint, primarily in the big toe, but it can show up elsewhere in the midfoot, in the arch, in the ankle, in the knees, the hip, the lower back, because it's all related.
They start compensating.
Exactly. Yeah. They start compensating, and you're trying to take the pressure off of that big toe joint, and you're walking all wonky, and it catches up with you. Sometimes if the hallux rigidus is bad enough, you can get some enlargement, some spurring. It can catch on the shoes, which can be painful in the dress shoe type of or tight, snug shoe type of options. So, what are we looking at clinically? Clinically, we see a bump sometimes. It can be enlarged. It can be inflamed. It'll be painful on range of motion exercises. Sometimes if it's been a busy day and they come see you, patients that come from work afterwards and it'll be red hot, swollen, you're like, all right, this is bothering you. And they're like, yeah, it's very tender. I've been walking it all day. It's been bothering me. What do you see?
Very typical. Yeah, I think this is kind of where you're thinking, okay, could this be gout?
Yeah.
Could this be just hallux rigidus? Could it really be gout on top of hallux rigidus?
Yeah, you can have both.
You could have both. So if they're really red hot and swollen, and to the extent that we see in a gout patient, where just the wind blowing by their foot is enough, or the sheets on their foot is enough to drive it crazy. That's where I'm like, okay, maybe this is gout on top of what's going on with the joint. Yeah. So that's why X-rays are really important. Yeah. And I know you've got some X-rays coming up here, but the clinical exam, you're gonna see they have tremendous pain with hallux rigidus at the end range of motion.
Yeah, that's so when you hit bone on bone contact.
That thud. Yeah, and that hurts because you've got loss of cartilage there. You've got bone on bone contact. Exactly. Yeah,
so what he's talking about is this joint here. Let me see if I can show it better. Your big toe joint, right? You got two joints, right? Your IPJ and your MPJ, and that MPJ is what's anchoring. So when we do that end range of motion, and if it's locking, it's a hard stop. That's that bone-on-bone contact. That's when we start thinking hallux rigidus or limitus, depending on the point or who you talk to. Or
it's kind of, I think of hallux limitus as the stages of 1 and 2 in the staging series, and then 3 is you just pretty much got a locked up joint. And that's really hallux rigidus.
And most of these patients will be having this problem on and off for months and months and years, and it'll just slowly catch up with them. So some of the other findings that we'll see, because obviously it's not an acute event, is we'll start seeing that callus, that
pinch
starts
callus
formulating under the IPJ when you have that limited motion, right? If you can imagine, if you don't have that motion in that joint, you're going to be putting all the pressure on your toe and trying to make up that motion at the IPJ.
Or they'll even rotate in the shoe and they'll roll off the side of the hallux.
That's when you start seeing the pinch callus on the medial side, and you'll get that that transfer lesion. You start getting the other metatarsals trying to take the pressure off of it, and you get that callus under the second, under the third, and sometimes you can get that spurring on the feet. I'm sure you see those quite a bit.
That radiograph you have right there at the bottom of your
this is just a lot
page,
of spurs.
That you're going to see what we call a joint mouse.
Yeah, that green arrow that's pointing to a joint mouse. That's like a osteophyte that's been floating in that joint, ends up becoming big and hypertrophic, enlarged, and ends up becoming a space-occupying mass in that joint.
And it just erodes cartilage there's no tomorrow. That's a pretty massive spur situation there.
So
you can see the joint's gone completely.
So, you see this all the time. What happens when you start losing that joint movement completely? You start making up in the most proximal joint next to it, the saddling of the first metatarsal cuneiform joint. Mm-hmm. So, as a nerve specialist, I'm sure you see this quite a bit. That medial-dorsocutaneous nerve or the deep peroneal nerve. Right. So that nerve crossing over that bump ends up becoming saddled between that bone and that shoe, and it gets pinched off like a rock in a hard place type of situation. And that can be quite painful. Nerve pain is the worst.
And it's just a contributor to the global pain that the patient's experiencing. So it's not just the joint. Sometimes it's the joint plus the bump causing the nerve issue.
Yeah, they'll come in presenting with one symptom. That could be the nerve. It's getting burning, tingling to that area. But what's causing that?
Yeah, the underlying bone lesion is usually the issue.
Yeah, it's a fun little puzzle. So what's happening? So this is when we were talking about the hallux limitus versus rigidus type of situation. You're getting that jamming of that joint. It's technically osteoarthritis. Mm-hmm. You're getting jamming of that joint. And over time, that wear and tear is breaking down that cartilage, that nice healthy cartilage, and ends up getting spurring and getting the that limitation, that bony prominence, which is stopping that motion at that first metatarsal.
You must have gotten this from a German website. The Engelschront and the Biwiggelschreit.
I thought the pictures were great.
They are great. I don't know how to pronounce that, though. The Erosion der Gleckenschritt.
Well, you did your fellowship, right?
That was in Russia. This isn't Russian. I have a hard time with Cyrillic as well, so don't ask me to speak Russian. I know just enough to find the bar, order a beer, and find a restroom. That's about all I can do.
Well, what happens? You come in, we see the patient, we do our little biomechanical exam. Sometimes it could be traumatic. It could be an acute injury. It could be trauma. It could be a hypertrophic head. It could be a flat head of the first metatarsal. But more commonly, it's a hypermobility of that first metatarsal at that medial column at the first cuneiform joint.
That I think is a huge part of this for the vast majority of patients who end up with this.
Yeah, I don't think they call it hypermobility anymore. I think they call it first-ray instability, right? I want to say.
Yeah, I still call it hypermobility, but yeah,
last few years.
First-ray instability, I think, is probably where they're headed with that terminology around that.
Yeah.
But
so what we see on a weight-bearing X-ray is that elevation of that first metatarsal, and the key is to get a clean X-ray, straight lateral X-ray, and your nurses or your radio techs will get decent X-rays that have the leveling aspect on the X-ray arm, because it could be falsely showing elevated.
If the foot's supinated, it's going to look elevated, so it's really got to be a nice lateral. Yeah, I totally agree.
But what you'll see is an elevation, and this is early, so you see that there's not too much osteophytes or anything going on here. So this is early. This would be like a stage 1, and we'll go through the stages. But over time, that instability, that hypermobility, whatever you want to call it, ends up allowing that first ray to jam at that first metatarsal phalangeal joint. When I have patients in office, I'll do a little test. You put 2 pounds of pressure on that first metatarsal, and you'll push up on that joint, and you'll see that they get jamming. But when they're sitting there, the patient's like, "Look, I have great range of motion," and I'll show you the before and after. Mm-hmm. I push down on that metatarsal, and that does what it's supposed to do. It's when you walk, your mid-tarsal joint and your subtalar joint locks. It supinates. It pronates the forefoot, which allows that first metatarsal to plantar flex, and then you get great range of motion. But when you have that instability, that first metatarsal will elevate. So you put 2 pounds of pressure on there, and that causes jamming. I mean, it's like 60 degrees to like 10 degrees.
Yeah, it eliminates the functional range of motion, and the jamming, you pay the price over years and years of the jamming.
Yeah, it's osteoarthritis of that big toe joint, and it's a biomechanical complication.
Right.
So what happens, and this is what you're talking about, the way that people compensate. They start walking out-toed. They pronate their foot, which causes the foot to unlock more. You end up walking more flat-footed. You walk out-toed, which causes the relative tibia to internally rotate, which causes you to become, what's it called? In-knee, knock-kneed, whatever it's called, where your knees are bending in. Yeah, genuvalgum. Yeah. Which causes your pelvic area, your pelvic bone to tilt forward, which leads to lower back pain, and it goes up the line and can cause lower neck pain. I mean, it's all related. The knee bone's connected to the...
You start getting cervical pain. Yeah,
it's that sudden locking, that sudden limitation, which you got to make up that motion somewhere else, be it the ankle, knee, hips, lower back, and etc. So...
The other thing that we'll notice is patients may have tried over-the-counter arch supports and other things that didn't work quite as well, because it's really hard to accommodate that particular problem without a very specific orthotic with a Morton's extension. I don't know if we have.
Oh yeah, I'm gonna go through the orthotics. Okay, cool. But yeah, you're on point. I mean, a lot of people will come in with those memory foam, the gel inserts. And you're like, look, these were great and comfortable for the first day or two you wore them, but the problem isn't that you're walking on stones.
Right.
The problem is that your foot's not functioning to its peak biomechanical ability.
The joint's locked up. It's you got to use a different approach.
Yeah.
That's really hard to replicate with something over the counter.
No, it's very difficult. So we'll get X-rays, and this will determine how bad the joint is. If it's early on, great, you can take care of it, and simple conservative options work great for these.
That's where orthotics are real helpful. Yeah. Because if you've got somebody that has hypermobility but their joint's not destroyed yet, you could do a first-rate cutout and allow that metatarsal to sit a little lower, and that improves the range of motion.
Here we go.
Yeah, first-rate cutouts work great. Now that's not going to work for someone whose joint's totally shot, because you don't want to ask the totally shot joint to do more work.
Yeah, when you've got a joint that looks like this.
Yeah, you're toast.
Or this. Yeah, you got no joint there left.
Yeah.
I mean, it's bone on bone. It's hypertrophic. It's painful. It's stiff.
Yep.
So that's when Dr. D was talking about this Morton's extension.
Yep. Oh man, is that Mike Tyson going down?
Oh yeah. So here are some conservative options that we can do to help take care of the pain. Right. When it's not too bad, we get that first rate cut out. When it's pretty bad and that joint is painful to move, we do that Morton's extension. Very opposite approaches. So if you have good joint still, we want to promote that motion, make it so that joint stays nice and healthy. When you start getting that arthritis in that joint, we want to limit that motion significantly. So that Morton's extension will still allow about 10 degrees of motion, depending on how stiff that carbon fiber or that plastic or that polymer is, and that's when we plane, if you want to do 2 millimeters or 3 millimeters or however thick you want to do it. But that mobility is limited at that big toe joint. Other things we can do conservative, we can get you into some like rocker bottom type shoe gear. There was a big thing with Skechers a couple years back, the shape ups. They're orthopedic style shoes that I guess Kim Kardashian and all these other people decided that they wanted to, get a couple bucks on. Yeah. Hey, it helps out people.
People who have ankle arthritis or hallux rigidus. I think this is a legitimate thing to consider.
And I do tell patients to get them. I tell them to get the Dr. Comforts, the Skechers. I tell them what to look for, because some of them have like some foam to them. I tell them the more rigid it is. I mean, there's a whole bag of tricks that you can do with simple rocker bottom shoes. And then when it comes down to it, if it's really painful, we can do steroid injections. Steroid injections are good, but they're short-lived. That's the only downside to them.
I think there is a place for stem cell.
Stem cell, of course, hyaluronic acid. There's a lot of things that we can do.
I think but you got to catch it relatively early. When you're at the stage that you were showing where you've got the hypertrophic, the really widened joint, and there's no cartilage left, your stem cells aren't going to do you much good at that point.
So you want to be at at this stage right here.
Where you're catching it relatively early.
Maybe even this stage when you're still catching it and you get them into an insole or orthotic that will help protect that joint.
So orthotic and stem cells. Because if you don't do anything for the biomechanical reason you're getting this,
a couple months down the line, it's just going to catch up with you again.
Spitting in the wind.
Yeah.
Not going to work.
All right. So we tried all the conservative options. We tried, shoes. We tried orthotics. We tried injections. Doc, it's too painful. I need this fixed. What are my next steps? So I can go through the whole classification system, but honestly, it's per patient. I mean, if it comes back, it's hypertrophic, it's painful. We do different procedures based on how badly damaged that first toe joint is. So the baseline is your cheilectomy, also known as your Valenti, right?
Just to clean out, get rid of the spurs, improves range of motion, but doesn't change the mechanics that caused it in the first place.
Yeah, these are good for older patients that, it's painful, but they're not good candidates for something more aggressive. Or this is good for someone who we can see that it's primarily just a dorsal osteophyte on both ends. We could take that down and get them into some orthotics or something, or some shoes that will help slow down the progression. Understanding that this may build back up over the years, but it will at least buy them a couple years before we have to do anything a little bit more aggressive. I use this sparingly. It's not one of my go-tos. I think there's a lot better options, but
I agree.
When certain patients fit the criteria, like I said, mostly for me it's older patients, that aren't good candidates for something a little bit more aggressive. But
the only time I've used this in the last 10 years has been in patients who had a serious nickel allergy and we couldn't use an implant.
Yeah.
So they didn't. We could fuse it or we could do the cheilectomy. So that's a pretty small percentage.
I actually had a patient with a nickel allergy, and we ended up doing this next procedure. If it'll go, there we go, a Keller. I like to do my Kellers with a Kraft. The original Keller was you literally remove that joint. It provides some space. Your toe is a little bit extra floppy, which is fine because it'll contract some and then get back to normal. You could pinch in the capsule and all that jazz. But now that we have grafts and I use umbilical cord for these, and I'll fold them over, I'll stitch them into a little square, cut it into a circle, and I'll tag them on two sides of that capsule, and then I'll tag it up top, so it'll
just resurface the whole metatarsal head.
It's like parachuting the joint, I think they call it. And here's a couple examples, different ways that other people have done them. This is a straight parachute, your classic technique for these, and this is they made it into like a little ball to make up that gap. I do mine
as
square.
A spacer,
yeah, it doesn't make a difference as long as you have a cushion between there. I think it works great. And like I said, these are for a set specific amount of patients. It wouldn't be something I would do for a long distance runner. I want something more functional for a long distance runner.
Right.
This would be something for someone who doesn't do too much walking or running. Your average, limited mobility older patient.
Agreed.
Here is a wedge resection. I think this one's called a Moberg, if I'm correct. I don't know. All these doctors have their own names to procedures. But you go in, you do a wedge to bring that joint up at the PIP.
It's kind of a cheater osteotomy.
Yeah. So you're not technically cleaning up the joint, but what you're doing is you're decompressing it just slightly, and you're bringing the relative angle of the toe 10 to 15 degrees higher. I've done these for certain patients, especially for patients who get the IPJ callus. I don't use the screw. I use a staple. That's my personal technique on them. But I think there's better procedures out there. I think I've done like maybe a handful of these in the last few years.
Yeah.
Not often.
I've never done one.
Yeah. Yep. There's better procedures.
Yeah, I've had such good success with the Youngswick and a Hemi. I like doing both. Yeah. The Youngswick's a great procedure because you can drop the metatarsal head about 3 or 4 degrees.
Yeah.
At 3 or 4 millimeters most of the time, and then if you need to, you can replace the base of the big toe with a Hemi implant.
So you're fixing both sides.
Yeah, you're decompressing and you're allowing the metatarsal head to ride in this chromium cobalt mirrored smooth surface.
Yeah.
And those implants, those hemi implants, the base hemis have been around for 60 years.
Oh yeah, they're old school and they work great. All these newer ones are more anatomic, which are like, I think they're like stage 4 or grade 4. I don't know what they're called anymore, but they're a lot more anatomic. The original ones, they used to use the Swanson implants. Remember those, the silicone ones?
Oh yeah.
But
took more of those out than I ever put in.
Yeah, I think the metal ones last a lot longer. And with the silicone ones, there's always that problem that you'll get the silicone reaction where it starts breaking apart and it fragments, and your body starts capsulizing those.
It can get into your lymph nodes. And
yeah,
there's some question about that.
So here you can kind of see the before and after. This is what it looks like before, a joint that doesn't have too much space. You can see the spurring, and here's the after. You see a little space there, but here's the trick to it. They do that cut, which allows it to drop down, and you have that 1 or 2 screws in there. I do my long arm on the plantar shelf. I don't know. People do it different ways, but it works. It's a tried and true, and it's one of my go-tos for Hallux Rigidus. It works so good.
Yep, I agree.
Cartiva, are you a fan of these? I'll be honest. I am not a fan of these. I think you have to do an adjunct to fix the problem, and if you want to use this to make up the difference, it works great if you have cartilage loss. But I think using this on every Hallux Rigidus or Hallux Rigidus case, it doesn't work.
Probably
for
not.
Traumatic Hallux Rigidus, by all means, because that's a pinpoint problem. You can go in and you could clean these up.
Yeah, if you had a specific hole in the cartilage,
yeah,
I don't disagree with that.
But
again,
on your vast majority of Hallux Rigidus, Hallux Rigidus type of patients,
you have to address the biomechanics.
Yeah,
and I think that's hard to do by just implanting part of the cartilage. But I know these are relatively popular. I don't want to throw them under the bus too badly, but I think that my base hemis do accomplish the same thing.
Yeah,
which is pain relief. The goal of the surgery is pain relief.
Engage
some range of motion, but the goal of the surgery is pain relief. And
so here are the implants that we'll be talking about.
Well, that's not there are no. Okay, there's the hemi. You got the hemi
right down
the
there.
Base hemi.
So it depends on what side of the joint you want to put it on, and that depends on the X-rays. But for the vast majority,
I don't. In my case, I don't think it doesn't matter to me. I don't care what the X-rays look like. If the joint looks like this one here in your middle screen there, I can put a hemi in there, and the patient will do great. So my choices are fuse it or hemi it at that stage.
Yeah.
And most people are like, well, if I fuse it, then I've got no range of motion. If you put in the hemi, I'll have 25 or 30 degrees of range of motion. Okay, I'll take that.
Yeah, I'm a hemi person too, and it's true. I do mostly base of the proximal phalanx myself also. It works great. I mean, it's tried and true. It works well. You're replacing that joint with a metal that's never going to build up osteophytes on it.
Never going to wear out.
You've decompressed it, and obviously when you're in there, you do your chylectomies. You're cleaning up the spurring on all sides of the joint, and it works. I mean, it's tried and true.
I think there are some issues with the head, the head ones. I think I've seen them dislocate. I've seen them, end up with subsidence where it gets very loose, and I don't know if that's just a mechanical problem. Those things are huge. They take up a lot of bone.
Yeah.
So I've taken more of those out than I ever put in, and the base hemis, I can knock on wood. In 21 years of using them, I've only had to take one out.
Yeah.
So it's a pretty good record.
Yeah, it's like your knee replacements or your hip replacements. You're replacing the problem site, and it works.
And the downside, or the upside to these is there's no plastic component to them. There's nothing that will ever.
Yeah, there's
wear
no poly like there is with like knees and hips
no poly,
and stuff.
So there's nothing to wear out. Yeah, they'll outlast the patient that you put it in.
Yeah,
by far. Yeah.
And then when all else fails, the fusion. And I think this is something that scares patients. When you tell patients that you're going to fuse that joint, it's actually, you honestly won't realize that it's fused. I mean, for the first couple of months, you'll notice that you walk a little bit different, but for the vast majority, I mean, do people notice that they've ever had the fusion? I mean, we have runners that are doing this. I mean,
yeah, I think if it's done correctly and you put the joint in the right position,
yeah,
you can have equal amounts of positive reaction.
That is true,
that
and that's a key component. I'm glad you said that, because a lot of people, will fuse the joint and they'll fuse it
too straight.
Yeah, too straight, and then your toe is sitting low, or it's even if it's at like neutral, you're still too low. I like to do mine about
5 degrees.
I try to go
Maybe a
for
little more.
10 to 15.
Yeah.
I put my gauze, I fold it up and I stuff it under there. I line it up. I throw my K wires. It works great. But yeah, and here's an example of, say we did a hemi implant or a total implant, and 10, 15 years later, it starts wearing out again.
Well,
God forbid.
And maybe not that the implant wears out, but sometimes it wears the bone out.
Oh yeah.
And
The implant's not going to wear its metal.
Yeah, you get a breakout in the bone. You get it starts to dislocate, and that's happened before.
Or joint infection.
Joint infection, another good thing. So this is great. You're putting a bone block in there, so you're getting the length back, and you're fusing the painful joint.
I mean, the hemis, they don't wear out often. I mean, I haven't had to take out one myself personally, so knock on wood.
The only one I had to take out was just for that reason, that the cortex on the base of the hallux actually broke through. Yeah. So we took it out and fused her.
Yeah, but when in doubt, you have this option. I think I've used the bone block more with Kellers of other doctors who've done them without a spacer, either without the hemi implant or the
flopping around.
Yeah, the collagen or umbilical graft in between, and then it's flopping around. It's bone on cartilage and it's causing them pain. And I'm like, all right, we have to go in and fuse this, and it works out great. And honestly, patients are super happy with this result.
It's a tried and true procedure, and there's really no reason to have to go back.
Yeah.
At that stage, if you do it correctly and the thing is in a good position, then you should be done with that as an issue.
Before, we used to use crossing screws, like you can see here, but now there's more anatomic plates. I'm a plate person for these. I don't know about you.
Yeah. The locking plates are great. They're really stable. It makes it easy to use bone graft underneath it if you need to. Yeah. You can even use the dynamic compression holes to get compression across it. So just technical details.
Yeah, fun stuff. I mean, if you guys want us to jump into more technical details of what we're thinking while we're doing through surgery, by all means, let us know. If you guys have questions, please let us know. We're here to help, because I could do an hour lecture on this and I still won't be done. I mean, it's a lot of fun talking about this stuff, but if it's boring you guys, by all means, please let us know what you want to dive into. And I mean, that's pretty much it. I mean, there's a lot of solutions for these problems, but you just got to let us know what these problems are. A lot of times with these hallux limitus, hallux rigidus cases, they'll just put up with the pain. Oh, it's just arthritis. It's catching up with me. My father had it. My grandmother had it, and I know I have it. But you don't have to live with the pain. We're here to help.
Absolutely.
Yeah.
Well,
anything else?
Fantastic. I think we're getting some weird feedback. Are you hearing that?
I think it's the AC.
Oh, it is. Just in time, the air conditioning kicks in. Don't bother asking a podiatrist for metric conversions. He only knows feet. That's great. Well, I would say that was a good 30-minute block of Hallux Rigidus. Thanks, Dr. Hussain, and we will see you guys next time on the PODdoctors.
Take care. Bye-bye.